So imagine you're walking into an emergency room and you have this just agonizing, debilitating back pain. Like you can barely stand up.
Right, yeah.
But then the attending physician pulls up your chart and they see a history of generalized anxiety disorder.
Mm-hmm.
Suddenly, the tone of the whole consultation shifts, right? The questions get a little more dismissive.
Oh, absolutely.
And this underlying assumption kind of solidifies where they think, well, this pain is probably just a physical manifestation of stress. It's psychosomatic.
Yeah, just take a mild muscle relaxant, go home, try to relax.
Exactly. And for millions of people, that scenario isn't just some hypothetical fear. I mean, it is a daily systemic reality.
It really is.
So today, we are looking at hard data that proves the healthcare system's tendency to just firewall physical medicine away from psychiatry is, frankly, a fundamental failure.
That's a massive blind spot. I mean, we've basically built this medical infrastructure that treats the human body like a car, right?
Right.
Where the physical hardware and the internal software are serviced in completely different buildings.
Yeah, by specialists who don't even talk to each other.
Exactly. We are treating patients in these rigid silos, and the data we're reviewing today shows exactly how dangerous that is.
Well, welcome to the deep dive, everybody. For you listening, whether you're a clinician navigating these silos, or maybe someone personally managing a chronic pain condition, or just a deeply curious mind, we are getting into the actual mechanics of why pain and mental health are inextricably linked.
And we have a mountain of evidence to get through today.
Oh, we really do. Our sources include the latest medical guidelines from organizations like NICE and PsyGN, the practical manuals from the Essential Pain Management System, and a truly monumental psychiatric umbrella review.
Yeah, that review is incredible.
I mean, we are talking about an analysis of over 957,000 patients with mental disorders, and that is cross-referenced against 16.6 million control subjects.
The scale of that umbrella review really cannot be overstated. I mean, when you have an N of over 16 million controls, you eliminate all the statistical noise.
Right.
You are looking at undeniable population-level truths.
So our mission today is to basically map out that invisible bidirectional link between chronic physical pain and psychiatric conditions.
Yeah, we need to explore the biological overlap and examine the staggering gaps in medical training, too.
Yeah, and eventually get to the biopsychosocial frameworks that are offering a legitimate way out for patients who are just trapped in this cycle.
Absolutely.
So let's start with that 16.6 million strong data set, because the sheer scale of the comorbidity here completely redefines the scope of the problem.
Right.
We know chronic pain is prevalent, obviously, but how much does the picture change when we actually isolate the psychiatric populations?
Well, it changes drastically. So just to set the baseline here, in the general population, the prevalence of chronic pain hovers around 20 to 25%.
Okay, so a quarter of the population,
Wait.
which is already a massive public health burden.
Exactly. But when you apply that lens to specific psychiatric cohorts, you leave that baseline completely behind. For patients with bipolar disorder, it stays somewhat close to average at 23.7%. But look at major depressive disorder, or MDD.
Oh yeah, the MDD numbers were wild.
For MDD patients, the prevalence of chronic pain surges to between 53.8 and 65%.
Wow. So the majority of patients walking around with major depressive disorder are simultaneously battling chronic physical pain.
Yes, the majority. And as you move into different diagnoses, the prevalence climbs even higher.
Right, because they looked at a mixed ADHD and autism cohort too, right?
Yeah, and the prevalence there reached 76.6%.
That's huge.
It is. But the absolute peak, like the statistic that really stops you in your tracks, is post-traumatic stress disorder.
Oh, man.
Up to 96% of individuals with PTSD report experiencing chronic pain.
Let's just pause on that for a second. Wait, 96%?
96%.
That effectively means that if a patient is diagnosed with PTSD, chronic pain isn't really a comorbidity, right? It's basically a near certain clinical feature of their daily existence.
That is really the only logical way to interpret a 96% overlap.
Right.
The data specifically notes that this trauma often manifests somatically, so most frequently as severe stomach, chest, or back pain.
The body is literally keeping the score.
A very agonizing way, yeah. And beyond the human suffering, there is a quantifiable systemic cost to treating these intertwined conditions so poorly.
Yeah, the financial toll mentioned in the sources is just striking.
It's massive.
We're looking at an additional annual cost of $5,208 per patient, specifically for individuals carrying both chronic pain and either depression or anxiety. And that's compared to patients without the psychiatric comorbidity.
Right, and the thing is that $5,000 isn't going towards specialized curative treatments.
Oh, really? Where is it going?
It's driven almost entirely by increased emergency department visits and lost productivity.
Wow. So it's just reactive care.
Exactly. These patients are caught in a crisis loop. They show up at the ER because the physical pain spikes to this unbearable level, but it's the underlying psychological distress that's driving that spike.
Right, and the ER is built to, cast broken bones and stop bleeding.
Yeah, it is fundamentally unequipped to untangle a complex neuropsychiatric pain web. So the patient gets a temporary patch, goes home, and the whole cycle just repeats.
Which naturally forces us to look at the causality. If the system is breaking down because these two forces, the psychiatric and the somatic, are colliding, which one is actually driving the car?
Right.
Like, is the chronic physical pain slowly degrading the patient's mental health? Or is the psychiatric disorder manifesting as physical agony?
Well, the data provides a very clear and honestly frustrating answer. It's both.
Really? Both?
Yeah, it's a bidirectional trap. The umbrella review quantifies this feedback loop explicitly. For instance, if you present with multi-site physical pain, your risk of developing major depressive disorder increases by almost 90%.
Almost 90%.
Yeah, the exact odds ratio is 1.88.
Okay, and that makes intuitive sense, right?
Yeah.
If you're living in constant physical agony, that would naturally deplete your serotonin and dopamine, leading to depression.
Exactly, but the reverse arrow is what's really fascinating.
Yeah.
If you start with a primary diagnosis of major depressive disorder, your risk of subsequently developing chronic regional pain increases by 26%.
Oh, wow. I want to replace the standard check engine light metaphor we usually hear for pain.
Okay, why is that?
Because that implies a purely mechanical failure. It sounds way more like placing a live microphone too close to a speaker.
Oh, I like that.
All right, it's this agonizing feedback loop. The psychiatric distress amplifies the physical pain, and then the physical pain amplifies the distress until the entire nervous system just blows out.
That is a perfect analogy.
So how does that biological overlap actually function, though?
Well, it really comes down to a shift in how we understand the architecture of pain itself. So historically, medicine viewed chronic pain strictly through a nociceptive lens.
Nociceptive, meaning there is visible, verifiable tissue damage.
Right. You have a ruptured disc, the nerves detect the inflammation, and they send a pain signal up to the brain. But this bidirectional trap relies heavily on nociplastic pain.
Nociplastic pain.
Yeah.
So we are moving away from structural damage and into nervous system sensitization.
Exactly. The neural pathways responsible for processing emotional trauma, anxiety, and depression, they actually share the exact same physical real estate in the brain.
Really? The exact same pathways?
Yes. Structures like the anterior cingulate cortex and the insula. They process emotional distress, but they also process physical nociception.
Oh, wow.
So when a patient is severely depressed or living with PTSD, their nervous system is bathed in stress hormones. It becomes hypervigilant.
So it's always on high alert.
Right. So a routine physical sensation, something that a healthy, regulated nervous system would simply filter out or maybe just register as mild stiffness.
Yeah.
That sensation gets amplified by this sensitized network into agonizing, burning pain.
So the subjective experience of a level 8 pain is entirely real to the patient, even if an MRI of their lower back shows absolutely zero structural abnormalities.
Yes. Their brain is quite literally generating the pain, but the suffering is completely somatic.
That is wild.
And to prove just how deeply psychiatric disorders dictate physical pain processing, the review highlights this fascinating but terrifying contrast.
Okay, what is it?
So, while depression and anxiety lower the pain threshold, making everything hurt, more individuals with schizophrenia actually exhibit an elevated pain threshold.
Wait, really?
Yeah, they have a significantly higher pain tolerance.
So they are processing nociceptive signals like actual tissue damage, but their brains just aren't sounding the alarm.
Precisely. And, while experiencing less pain might sound like a clinical advantage, it is actually incredibly dangerous.
Because pain is a warning system.
Exactly. Pain evolved as a critical survival mechanism. Because patients with schizophrenia have this glunted pain response, the data shows a severe delay in the diagnosis of life-threatening physical diseases.
Oh, no.
Specifically cancer.
That makes total sense, tragically.
Right. The tumor grows, the tissue is damaged, but the altered neurochemistry of their schizophrenia actually suppresses the pain signal until the disease is highly advanced.
That perfectly illustrates why treating the mind and body as like completely separate entities, is basically lethal.
It really is.
But if this neurobiological overlap is so thoroughly documented, I mean, we're talking about an umbrella review of 16 million people, why is the clinical application so far behind?
Yeah, that's the big question.
Because the sources point out that in Europe, patients face an average 2.2-year wait just to receive a formal pain diagnosis.
Right.
And then another 1.9 years to get adequate management. 4 years to manage a recognized condition. Like, what is the bottleneck here?
The bottleneck is a phenomenon called diagnostic overshadowing.
Diagnostic overshadowing.
Yeah, and it goes back to the scenario you painted at the very beginning of our deep dive.
The ER patient.
Right. When a patient with a known psychiatric history presents with physical symptoms, clinicians routinely and often subconsciously attribute the physical complaint to the mental illness.
So the psychiatric diagnosis literally casts a shadow over the physical symptoms, making them invisible to the doctor.
Yes. The doctor assumes the somatic complaint is just the anxiety talking. Crucial diagnostic tests aren't ordered. Referrals to pain specialists are delayed.
Oh, man.
The physical pain is overshadowed, which leaves the patient stranded in that 4-year waiting period you just mentioned.
I struggle to accept that highly educated physicians fall into this trap so universally. Like, are we really saying a trained medical professional can't distinguish between a panic attack and nosoplastic regional pain?
Well, look at the data on medical education that's included in the UK guidelines.
Okay.
Across their entire multi-year medical degree, UK medical students receive a median of only 13 hours of pain management education.
Wait, 13 hours.
13 hours.
You could literally binge watch a single season of television in the time it takes to cover pain management for an entire cohort of future doctors. That's insane.
And it isn't even a dedicated, cohesive module usually. It's scattered piecemeal across different specialties.
Oh.
We are sending physicians into the field fundamentally unequipped to untangle the neurobiology of nosoplastic pain. So when they're faced with a complex presentation, they fall back on diagnostic overshadowing because they simply don't have the training to navigate the nuance.
Which kind of forces the question, right? If we can't completely overhaul medical school curriculums overnight, how are the modern guidelines attempting to bypass this lack of training? Like, how do we force clinicians to stop overshadowing these patients?
By standardizing the workflow. This is where the Essential Pain Management, or EPM, system comes in.
Okay.
They introduced a very rigid acronym to force compliance, RAT.
R-A-T-V. Right. Recognize, assess, treat.
Okay, the RAT framework. But let's look critically at the recognize and assess portion for a second.
Sure.
Because the guidelines mandate that pain must be treated as the 5th vital sign, meaning you check it just as ruthlessly as temperature, pulse, blood pressure, and respiratory rate.
Exactly.
To do this, they relied on the 1 to 10 number score, or the FACES pain scale.
And I have to push back here. Is quantifying a highly subjective, emotionally driven nosoplastic pain state on a simple 1 to 10 integer actually medically rigorous?
Well,
or is this just, bureaucratic box ticking so a hospital can avoid liability?
it is a highly debated topic. And honestly, the guidelines completely concede that a 1 to 10 scale is an incredibly blunt instrument for such a nuanced subjective experience.
Right. A 7 for someone with PTSD is biologically totally different than a 7 for someone with a broken femur.
Exactly. However, the value of the 5th vital sign isn't in the mathematical precision of the number. The value is in the mandate to record it.
Oh, I see. It forces the conversation.
It forces recognition. By making the clinician ask the question and formally log a number in the chart right alongside the patient's blood pressure, you pull the patient's suffering out of the shadow of their psychiatric diagnosis.
Yeah. You establish a formal, validated baseline.
Exactly. You cannot dismiss a patient's pain as just their anxiety once you have legally charted it as an 8 out of 10 vital sign.
Okay, so it's basically an administrative safeguard against diagnostic overshadowing. I definitely see the utility there.
Yeah, it changes the workflow.
But that brings us to the final letter of the RAT acronym, treat.
Right.
We've validated the patient, we've charted an 8 out of 10. But if 40% of chronic pain patients have a comorbid psychiatric struggle, handing them a standard prescription for NSAIDs or opioids isn't going to fix the nosoplastic feedback loop.
No, not at all.
So what does the evidence say actually works?
The guidelines are unequivocal on this. Interdisciplinary pain treatment is the absolute gold standard.
Interdisciplinary.
Yes. You cannot treat a biopsychosocial problem with a purely biological pill. You have to integrate physical medicine, physiotherapy, and psychological intervention.
Right. But let me guess, the vast majority of patients never receive this level of care
You guessed correctly, most do not.
because it's expensive, and as we discussed, the system is completely siloed. So how do the guidelines suggest we bridge that gap?
It requires a massive paradigm shift that the sources refer to as the 5C approach.
5C approach, what is that?
The core of this is moving away from the traditional prescriptive medical model. Historically, the doctor asks, what is the matter with the patient?
Right, trying to find the broken part and cure it.
Exactly. The 5C approach flips that completely. The clinician must ask, what matters to the patient?
What is the matter versus what matters to you?
Exactly.
But that requires admitting that the medical system might not actually have a cure, right?
Yes. It is a sobering but deeply necessary shift. Both the clinician and the patient must acknowledge that for chronic nociplastic pain, complete eradication of the symptom is rarely achieved.
So the goal shifts.
Right. The goal shifts from cure to optimizing function and quality of life.
Okay, so what are the actual mechanics of optimizing that function? Like, what does the trial data show regarding psychological interventions?
Well, let's look at cognitive behavioral therapy, or CBT, first.
Okay.
The clinical trials show that CBT has a relatively small effect on actual pain reduction. It doesn't really silence the nociceptive signals, but it shows a highly significant improvement in coping mechanisms.
Which makes sense. CBT is all about restructuring your cognitive response to a stimulus.
Exactly.
But what about the data on mindfulness-based interventions, or MBIs? Because mindfulness is frequently marketed as this absolute panacea for chronic pain.
The MBI data. This offers one of the most profound aha moments in the entire stack of sources.
Really?
Yeah. The randomized trials show that mindfulness does not significantly reduce the severity or the intensity of the physical pain.
Wait, it doesn't?
No. The raw sensation remains pretty much unchanged. But MBIs cause a massive, statistically significant decrease in pain interference.
Pain interference. Okay, let me see if I can map that out.
Go for it.
It's like you're driving down the highway and an incredibly loud, piercing car alarm starts going off in the back seat.
Right.
The traditional medical model tries to cut the wires to the alarm. But if that fails, the noise is so overwhelming you just have to pull over. You stop living your life.
Exactly.
So mindfulness doesn't actually lower the volume of the alarm, but it trains your nervous system to tolerate the noise, keep your hands on the steering wheel, and just continue driving to your destination anyway.
That is a brilliant distillation of the data. The objective intensity of the alarm is exactly the same, but it loses its power to dictate your behavior.
You reclaim your functionality.
Exactly. And we combine this with physical interventions. The research shows that physical modalities, like acupuncture, for example, when paired with standard medical care, significantly outperform medication alone.
Oh, wow.
The multimodal approach really is the only way to break the bidirectional trap.
Okay, I understand the clinical efficacy of that.
Yeah.
But we have to address the logistical reality here.
Sure.
We just discussed how chronic pain and depression incur an extra $5,200 per patient annually in emergency visits alone.
Right.
How on earth do we scale a gold standard interdisciplinary model involving CBT, mindfulness training, acupuncture, and medical management to a quarter of the global population?
Yeah, that is the ultimate friction point. And the guidelines recognize that human capital is just too limited to provide a bespoke interdisciplinary team for every single patient.
So what's the proposed solution?
It relies heavily on digital self-management tools. We're talking about clinically validated apps, online CBT modules, and virtual health tracking.
Okay, apps.
But the sources issue a very stark warning alongside this recommendation.
The digital divide, I'm guessing.
Precisely. If we rely entirely on automated digital tools to scale pain management, we risk severely widening healthcare inequality.
Because patients who lack digital literacy or reliable broadband or just the financial means to access smart devices will simply be abandoned by the system.
Exactly. And over-reliance on tech actually punishes the most vulnerable demographic.
So what is the middle ground then? How do we balance that?
Hybrid models of care. This is really where the future of pain management lies.
Hybrid models.
Yeah, you leverage the infinite scalability of digital platforms. So the patient uses an app to guide their daily mindfulness, track their pain scores, and complete their CBT exercises.
Right.
But that technology is directly tethered to a human facilitator.
Oh, okay. So they aren't just screaming into a digital void.
Right. They have Scheduled, perhaps virtual check-ins with a nurse practitioner, a physical therapist, or even a trained community health worker.
That makes a lot of sense.
The human facilitator reviews the data, keeps the patient accountable, and most importantly, provides the empathy and validation that an algorithm just cannot simulate.
So you achieve this scale of technology while preserving the actual clinical alliance.
Exactly.
Well, that feels like a grounded, realistic framework for a system that is currently just buckling under its own weight.
It really is.
To pull all these threads together, what our deep dive reveals today is that chronic pain simply cannot be dismissed as a mere symptom of tissue damage.
No, not at all.
It is a complex nosoplastic disease state that shares fundamental neural architecture with our psychiatric health. Treating a patient's physical agony while ignoring their depression, or treating their PTSD while completely dismissing their somatic pain, is a catastrophic failure of clinical logic.
Absolutely.
But by embracing the what matters to you paradigm, mandating the fifth vital sign to fight diagnostic overshadowing and scaling interdisciplinary care through hybrid digital models, we finally have a blueprint for patients to reclaim their lives.
It is a blueprint that demands we look at the entire human being. And as we wrap up, there is a fascinating corollary to everything we've discussed today.
Of that.
We have spent this time analyzing how mental health struggles create and amplify physical pain. But if these conditions are truly bidirectional, if somatic pain and emotional trauma share the exact same real estate in the nervous system, it raises a really profound question about the future of psychiatry.
Which is?
Could the future of treating severe mental illness actually rely on physical, body-based therapies?
Yeah.
If we are learning that we must use the mind to effectively manage physical pain, it stands to reason that the next frontier in psychiatric care will rely on physical interventions to heal the mind.
Reversing the flow of the bidirectional trap. That is an incredibly powerful thought to leave on.
It's an exciting frontier.
Thank you for joining us on this deep dive. For everyone listening, whether you are managing your own complex health journey or advocating for a patient, we encourage you to listen to the whole system, challenge the medical silos, and keep exploring the profound invisible connections within your own biology. We'll catch you on the next one.